This is David Harlow at HealthBlog, and I am pleased to bring to you today a roundtable discussion about blockchain in healthcare, National Health IT Week. I have with me today a couple of experts in the field, and I'll be introducing them to you in just a moment. It is National Health IT Week, and there are a number of observances and meetings and conversations happening this week. Many of them, in fact, are around the question of the use of blockchain in healthcare. And as some of us are less technically adept than others, we know generally that blockchain in healthcare is a means of securing information, transmitting information, sharing information securely in a trust environment. And we're going to hear more about what exactly this means and how it can be used. But also this week there have been meetings at NIST and ONC, and I hope that some of our panelists can speak to what's been going on there and what's been going on in this field generally and what we can hope to gain in the future and how far off this future might be. Well, so I have with me today Leonard Kish and Peter Nickel. Leonard is a longtime health IT operative, let's say, and he's been working in neuroscience, he's worked in technology, and his observation is that he's been really working over time to decentralize many systems, and blockchain is really just another step in this process of trying to decentralize control over information, control over systems. He's been writing about blockchain for a couple of years, and he's been working on some specific solutions, which I hope he'll tell us about as well. Also with us today is Peter Nickel, and Peter has been writing and thinking and doing a great deal in this field as well. He is going to be telling us about the opportunities and the potential pitfalls here on the road to adoption. Welcome, Peter.
Thanks.
So I think what I'd like to do to just sort of kick this off is, again, I am not a super technical person, and I'm surrounded by people with much more technical knowledge than I have. I would hope that one or both of you would be willing to offer an explanation of what blockchain is. What does it mean? We know about blockchain in as it relates to Bitcoin in the popular imagination and the popular press. But what is it exactly, and how does it relate to healthcare security? Is this something that is really going to make a real difference in people's lives? Is it just something that's under the hood that we don't really need to know about the details? Or some of us, even if we don't really understand it, we want to know, why is this a good thing? How is this a good thing? Gentlemen, I put it to you.
Sure. Leonard, why don't you kick it off, and then I'll fill in.
Sure. So what is blockchain? As you mentioned, David, and thank you, David, for having me. It's the underlying technology. The first use case is Bitcoin. But it's essentially a way for a lot of computer systems and a lot of individuals to agree upon a single version of reality. And that reality can be kind of transactions in the case of Bitcoin, or it could be data or a lot of different things that can happen that are written to a common, people refer to it as a ledger, but it's really just a long list that people agree upon is kind of the version of the truth that can't be changed. And so with that comes a lot of opportunity for healthcare. It's really decentralizing a lot of information from silos in the Bitcoin idea. It's, if you're putting all the transactions out in the open, it's decentralizing them to a common framework. And I think the big opportunities people are starting to see in healthcare is, you can do a lot of the same things, that in healthcare, probably trillions of dollars are lost because of these silos that don't have the rights or the will, the incentive to exchange information. And I think a lot of people are looking to blockchain as a way to get around some of that.
Thank you. Peter, something to add there?
Sure. It started from the financial services back in, the 2007-2008 financial crisis, when there was a lot of mistrust with the banking system in general due to, subprime loans and a lot of the mistrust that happened when the housing market crashed. And as a result, Satoshi Nakamoto, the group or individual wrote a paper on how to kind of remove that intermediary in that third party. And in the financial system, it'd be a Visa or MasterCard or Western Union. And in healthcare, it's kind of interesting because now we're trying to explore and figure out, well, who would that intermediary be? And, sometimes the intermediaries are, helpful, like in the case of going to the grocery store and buying milk. You don't have to drive to the farm and wait for the cow to get milked, right? On the other hand, sometimes there are challenges. And if you went to that same grocery store to buy a product, and instead of one cashier, there was 5, and each of the cashiers had a different system to scan your items to get you out the door to get home to make your sandwich, for example, then it wouldn't be very efficient. And I think what we're trying to figure out is how do you identify those intermediaries and ultimately remove them from the equation. One thing that comes to mind when I think of how to explain blockchain to somebody who's maybe not familiar with the concepts or maybe isn't into the weeds as we are trying to apply it into the health space is, if you think of the last time that when you're like a little bit younger and played some board games like say Monopoly, if you probably played a game with a brother or sister or somebody who maybe wasn't the most trustworthy person when it came to the game. And, sometimes when you're trying to, after the second or third hour, you ultimately wanted to get up and go to the bathroom or get something to drink. But you didn't really want to. And why was that? And the reason was trust. You didn't really trust them that they'd keep the board the same, that they wouldn't take your car and switch it for the horse or move you a couple positions or take your houses or hotels off your properties. So part of what blockchain does is it allows for that board to be unchanged and allows you to step away from the board and know that you can come back and it will be exactly the same. And if it's not the same, then as Leonard mentioned, then you have this record. And it's kind of like writing on the back of the board saying, Peter has 2 houses and 4 property cards and low on cash with only $20. And I come back and I know that I should have this cash and these houses and this property. And that's kind of the idea of the immutability where it's a permanent record. And we're starting to see, lessons from the financial sector of how this can potentially apply to healthcare, and it's really exciting.
Great. So I understand the idea, at least conceptually here, that we're looking for something that is, as you say, immutable and trusted. In the context of delivering healthcare, I'm trying to think of the use case and how it could be used. Sort of the extreme use case that comes to mind for me is the individual who comes into the emergency room and we need sort of a break the glass protocol, if you will. How do we get the information? If the goal is to transmit and store and share health information about an individual in a way that can be accessible to healthcare providers when needed, how would that be accessed in a situation where someone comes into an emergency room, not necessarily in their quote-unquote home hospital?
Anyone? There's a few different ways to go about that. But let's back up a little bit. There's kind of on-chain, what we call on-chain storage, which is just a listing of the transactions that happen in a blockchain kind of a scenario. And then what we're seeing a lot of interest in regards to healthcare is what's called off-chain storage. So you could have a decentralized database that's not actually part of the blockchain, but you could use addressing schemes that could list data transactions to the chain itself that could then point to information that's off-chain but still kind of decentralized and available. And within that, you can there's a lot of different permission schemes about you can offer that will allow people to give different rights and controls over different subsets of information. So in that scenario where somebody wound up in the emergency room, there could be an application even on their phone that's a kind of a break the glass application that shows a private key, and that key then releases a lot of their health information through like a QR code or a lot of the stuff that you see in Bitcoin today.
Okay.
Yeah, I agree. I'll chime in. First off, it's not going to solve every single problem. When we looked over some of the early notes, David, you mentioned like an unconscious patient, right? Obviously, it's pretty tough to get an indication from somebody who isn't conscious. But there's a lot of applications, as Leonard mentioned, that do apply. And, the first thing that kind of comes to mind is the whole trust between the doctor and patient. When you go to the doctor and you're getting, some level of service, for example, whether it's a checkup or a cold or a prescription, you trust that the doctor is making decisions off of accurate information. You signed up and the receptionist took your name, and now they don't ask for social, but at least it's a lot of other information, your insurance, background and history and things like that. Well, when you get into that actual, room to do the evaluation, what additional information do you have? Do you validate your social with them, or your name, or your, date of birth, or hey, the last time I had, my triglycerides, paneled, it was a little bit high. Remember what those were? None of those checks happen. So that kind of goes to the fact that 12 million people a year are misdiagnosed. And part of that is, due to bad information that the patient is providing. But a lot of that is the doctor is making decisions on poor information. It's not integrated, and it's not interoperable between different networks. So one of the benefits of blockchain is to be able to provide that level of trust. And if you kind of expand what Leonard said, and maybe that application provides a way to authenticate that the doctor is really looking at that correct record, and that your medical history and your wellness and kind of the holistic you is accurate and it's not misrepresented, to make sure that you're getting treated and the diagnosis that's most effective for you individually.
Okay. So what I hear you saying is that the information that we have now is sort of not very good, not very trustworthy, and not necessarily very useful, and almost anything would be better than that. Am I misstating that?
That's certainly a little bit. That's that's part of it, but I think a lot of it is that right now we can ask for healthcare records. We can we can get data from an API from a health app, but there's no really common place to put that. So I think part of the first step is creating a common framework by which you can first collect that information as an individual about yourself. Then you can get to how do you share it outwardly and what are the rights and circumstances around that.
Sure, I think that's a very important point. There's a huge proliferation of apps and tools and trackers and sharing platforms, and as you say, the real issue is there isn't necessarily a central store that's recognized by consumers and healthcare providers where all of that can link back to.
And a big part of that is because any third party that you're going to entrust to manage that kind of information has to have an extreme amount of trust. And when people talk about trust in blockchain, the idea is that you can create an environment like that, but you don't need to trust a third party with it. The trust can be kind of enabled by the math of cryptography.
Okay. So again, let me push maybe push a little bit too hard on this issue. Again, as a non-technical person, how is that helpful? How is it both protective of the information, and how does it simultaneously work to make the information accessible where needed?
So let me try to answer that 9-part question there.
Okay.
One, I think there's a misnomer that the immediate consumer and care experience in terms of care delivery will dramatically change. That's not going to happen. From a consumer standpoint, they're not going to walk in tomorrow and have this totally new blockchain experience.
Right.
Like, some type of design thinking experiment that happened for Mayo with Jack and Jill. It's not going to be like that. What's going to happen is it's going to be kind of like the battery effect of the iPhone 7. Let's just say that it increased by 20%. You kind of don't care how it increased. If they made the phone a little bit bigger, which they tend to do, or if they use the latest nanotechnology to re-architect it and decrease the size of that circuit by 20% to cram a bigger battery in. From a consumer, you go in and you see an AT&T sign and it says 20% bigger battery life. And you're like, hey, cool, I think I'll get involved in that. I think I'll buy that product because it's 20% larger and has a little bit bigger, capacity. That's kind of what's going to happen with the consumer side. They're not going to necessarily see that this is all blockchain and this is the new care experience. What they're going to hear is there's a system that has a little bit more trust. Some of these experts are telling me it has more trust, just like the battery life has increased 20%. Does a consumer need to know all the details of why it's 20% greater? No. And the same thing on the patient side. The patient really doesn't care what the EMR system is that the hospital is using. They don't care. So we're going to see kind of like a little bit of a difference from a consumer standpoint on what the perception is and what the actual experience and the care experience. Hopefully what we'll see is different outcomes getting driven as a result of this additional trust layer, whether it's in an application or whether it's, on some type of, broad entity that allows for aggregation of information and in the form of like, what blockchain provides. So from a consumer standpoint, they're not going to see a dramatic difference. I think from a provider standpoint, at least the hospital systems that I've been recently talking to, what they're interested in is a way to prove that they're trustworthy. There's no longer like, well, take the doctor's word for it, or just believe us that your records won't be compromised. It's a way to prove and establish that layer of trust. And what we're seeing on the other side, on the consumer visible side, is 237 health breaches since 2016, 13.5 million records breached. So as a consumer, I don't really know a lot about technology, let's say, but that doesn't sound good. And being part of the Blue Cross, breach, I have a little bit more invested interest to be like, hey, wait, I could get involved in that. So from a consumer standpoint, I think the transition will be almost transparent. From a provider and payer, I think they're realizing that there's some applications that improve trust pretty quickly with patients and members that is worth exploring.
Okay, so what do you gentlemen see as the growth potential here? World Economic Forum has said that sort of I think 10% of world GDP will be stored on the blockchain within 10 or 12 years from now. What does that mean for the U.S.? What does that mean for healthcare? Is this happening tomorrow? Is this happening in 5 years? Is this happening in 10 years?
I think the first places we're going to see it are around clinical research, giving people a way to receive their information if they're part of a study, and then be able to share it back out in further studies. I think the real value proposition is there. It's kind of accepted. So I don't think it's going to happen, directly in the healthcare system yet. But I think there's a lot of interest in seeing people pull information from their EHR, from their studies that they're a part of, from apps that they're a part of, into a trusted environment where they can control the sharing and access of it. I think payers are probably the next, and providers will be dead last, as they often are.
My take is like, I think what we're going to see is we're going to see exploration from the biggest part of the market. So from a financial services standpoint, that we're interested, to decrease that level of payment. So in the transfer, the handoff of that contract, whether it's a derivative or whatever the contract structure is, it's to decrease the number of intermediaries. On the healthcare side, there's a lot of intermediaries, but they're not always, not all adding zero value. Some of them are adding value and are useful. So I think what we'll see is you'll start to get areas like government and other areas, say Medicaid, Medicare, where you have beneficiary payments. It's kind of like a Bitcoin type thing where you have an asset transfer, and they'll start to focus on the big nugget, which is really fraud and abuse. And they'll start to say, okay, well, we pay out X billion dollars a year in Medicaid annually. How can we try to shave off 1% or 0.5%? And when you start to look at those numbers, it's a lot of money. So providing some type of entity or utility into that ecosystem that provides insurance that people aren't paid twice adds a lot of value.
Yes.
Yep.
Is there, so you see that as sort of the first cut, something that's most attractive?
I think that's how ultimately it's going to gain like legit adoption. I think what we're seeing now is
that's the foot in the door.
Yeah, I mean, I think what we're seeing initially from a starting standpoint is a lot of proof of concepts. And Leonard, I read your paper real quickly a few minutes ago. Very cool on the whole proof of evidence and stuff. And I guess my thought is, thinking of like James, Jamie Kirk, 2013, coming up with proof of evidence and coining the term as a result of working at IDG or CIO.com. What it reminds me of is that level of like immutability. So some type of like receipt of something. And why do you get a receipt when you go to the store and buy something? Well, it's kind of good to have a copy to know what you paid in case you have to return it and have that permanent copy of that transaction. And if you apply it to healthcare, well, what will that mean? Well, maybe it's a permanent copy of your visit or your diagnosis or some other types of information. And then when you start to apply that broader, more broadly, you can start to figure out other cool ways to use that information. But it's going to start as basically a bolt-on to larger systems. And as an entrance level, we're not going to see like blockchain company A get created and then start to integrate with all these different EHRs or go into different provider networks. What we're going to see is existing vendors that expand current capabilities with their existing software models that already have inroads and channels into these different organizations. They have the contracts already created. They already have a product that they've built and developed, so they don't need to recontract. They can just add it on, and you can leverage it or not leverage it, but it's an additional feature that their client base can consume or not consume. And that's probably how we're going to see that technology initially start from a pilot standpoint and then get greater adoption.
Yeah. I saw this week at Health 2.0, Pocket Doc announced what they call DocChain, and that is sort of a blockchain approach to doing what they have been doing with APIs. Their presentation basically said, APIs are a way of dealing with the legacy systems that we have that are broken, and the blockchain approach is sort of their stab at the wave of the future. Leonard, could you say a little bit more about what you're working on? Peter alluded to it. It'd be interesting to hear what you're doing.
Yes, so Ubase, it's youbase.io is the website. We've just released our alpha platform at developer.ubase.io, and it's an off-chain storage mechanism specifically built for structured data to give individuals control over specific data points. So in their wallet, on your phone, say, or on your computer, wherever you host your wallet, you'd have a store for your own personal information that exists in a structured format. You can then share your public keys to that information and keep much of that, who that information is coming from, anonymous. From the exterior, all those public keys look completely random. There's no way that you can connect them, but then on the individual's back end, they can connect them and share them as needed. So it's a way for people to manage their own individual structured health data. And we've released the initial platform. We're releasing the hosted version of the platform in a couple of weeks. And we'll be releasing a messaging component of that so that you can actually message some of these data points before the end of the year. I think that'll have specific valuable use cases in clinical research in particular, where people might find an interesting biomarker. Currently, because a lot of the data is anonymous, don't have a way to message back to an individual and build that capability. We have a video that I'll share in a link block if I can do that somewhere, for people to go check out the video on YouTube.
Yeah, and if not, I'll be doing a follow-up post and I'll share that link as well, Leonard.
Thanks.
Hey, question. What's your take on on-chain versus off-chain? Private versus public blockchains.
Well, those are kind of two different things, right? On-chain and off-chain. You can have on-chain storage that's a private blockchain, but off-chain storage means you're linking somehow to the blockchain that maybe a data transaction has occurred, or that a piece of data is, maybe it's a content addressable store, meaning you create a hash of the data that you then store on the blockchain that points back to it. The blockchain kind of structure is really good at recording the transactions and making them immutable, but what it doesn't do is, the performance is not particularly fast. So for a lot of structured data, to treat it as a database, it's not going to work in a lot of circumstances. And so off-chain, if you look at the ONC white papers, a lot of them talk about off-chain storage, and that's where I think a lot of the direction is heading for larger volumes of data and for structured data.
Cool, thanks.
In terms of public or private or permissioned or permissionless versus permission blockchain, I think we're going to see all different flavors. I mean, this is so nascent. I think a lot of folks, particularly with the anonymity and security and privacy aspects of healthcare, will actually see probably a lot more private blockchains to start. But I do think that we in particular are experimenting with putting things on the Bitcoin blockchain in certain use cases.
Cool.
Leonard mentioned these white papers. Peter, I know that you had submitted something there. Can you speak to what you were looking to, you were proposing there?
Sure. We submitted two different papers. The first one was on a crypto citizen. So the idea was around the identity of a citizen for the benefit of kind of a public identification. So similar to how you'd have a driver's license and other types of unique identifying information, you'd have some type of ID, but it'd only be like a health ID that would follow you. And the second paper that I submitted with Dr. Bill Daly was around patient identities and trying to figure out a unique way of identifying patients between healthcare providers. So you go to hospital one, and then 2 days later you have your labs done, or you go for a basic checkup. They don't have that information. So how do you create some type of health phone book that allows providers to look up patients and uniquely identify them? And we outlined some different mapping algorithms to efficiently do that. I think just looking at it, and first, I think overall there was like a lot of really cool submissions. At least the ones that we could see. I kind of grouped them into three buckets. One was like the first bucket was like truly inspirational, like original ideas, articulated well, and you kind of wanted to get to the end quickly to understand the idea. The second idea was like healthcare specific, but not contextually relevant to blockchain. So you could tell that the person who wrote it was knowledgeable in healthcare policy, but didn't understand how to apply it to blockchain. And then the third, frankly, was just kind of totally fluff and inefficient. And it didn't add a lot of value, in my opinion. I think that some of the papers, like specifically IBM's, was a great approach of a lot of different capabilities that could be done from blockchain. And that broadly, you had a kind of like two groups of folks. You had one folks that was, kind of a shotgun approach of, here's all the different ideas that could possibly be done with blockchain. None of them were elaborated or articulated enough to be actionable or to go into a pilot. The second group, which is the group we took, which was take a specific blockchain idea and mature it to the point where you could say, yeah, this is cool. Let's do a pilot with this. And I think that was probably, part of the challenge with the competition a little bit, the difference in perspectives of how people responded. Overall, I was a little surprised that out of, say, 70, 80 respondents, that of the 15 that were selected, 53% were from big, large, multi-billion-dollar firms. And that just statistically, that's not too likely in terms of probability. And that when I think of, those submissions, it would have been like probably a little bit more efficient if there was some type of like truly blind evaluation. I know when I judged a competition in the UK on some of the, cool technologies and innovations for like, teens, all the reviews we done were anonymous. So you had all the information on the candidate and the candidate team and videos and all this stuff, but you didn't know who it was. I think that would probably have been an effective way to do it, because somehow I think a little bit of bias got in there, but.
Right, yeah. It's hard to do. I mean, there's certainly a way of doing that, but unclear what happened there. Have either of you followed what happened at the NIST conference over the last couple of days?
Only very generally. Our CEO, Michael Dillon, was there and had a lot of great conversations, but I'm just catching up on the specific conversations. On the white paper challenge, I thought the one that collectively seems to be the standout among a lot of people that I talked to, and I thought the same, was the MedRec. I think it kind of walks the line between articulating the potential, having a really well thought out solution, plus having the backing of Beth Israel and MIT. So if people are going to read one ONC white paper, I'd definitely recommend that one.
The other thing that comes to mind is like, a lot of you have kind of like two camps, right? One are products and services that had already been created, right? In that example, some of that was created in 2013. So very cool, innovative technology like 3 years ago. This is my perspective.
Yeah,
it was published in IEEE several times and had a lot of visibility. So, yeah,
I also noticed that and there weren't a lot of vendors included in the winners, and I think the ONC mission is certainly not to pick winners. So when you have a contest like that, you kind of have to. It seems like they might have to default. I'd love them to tell me that they're wrong. They might have to default to individuals, academics, and consulting companies, which was basically who the winners were.
Happened, yeah. It'd be fun to see all the papers, though. I mean, I think of like really cool papers. Like when I think of like the MIT blockchain discussion that happened, about a month and a half ago, all the different discussion was on the blockchain, and you could go to Reddit and go to different types of tools and read everything that was posted. It was pretty cool. It'd be interesting that while they're talking about blockchain and full transparency and digital letters and immutability, only the winners are online to view, and there isn't full transparency on what was submitted. It'd be cool to see like all the different folks that submitted and what they were talking about, because I bet there were some really cool ideas. I mean, I talked to a couple, some doctors and a couple of developers that submitted some really cool papers that haven't gotten any visibility. It'd be interesting to see kind of like what the breadth of the submissions that they received were. From the sideline, of course, just chatting away on a,
Right. So of the ones that were available, were you surprised by the range of issues that the papers attacked, or not necessarily? It sounds like you're both saying that there's opportunity for broad applicability of blockchain within healthcare, although each of you seem to have a particular perspective and area where you think the early opportunities are going to be.
Well, it's ONC, so I think they were all necessarily provider-centric as well. but I think a lot of the use cases and therefore kind of institution-focused solutions. I definitely come at this more from a consumer and that decentralization aspect. So it's kind of like reading white papers about decentralization from the current centralized players and how they might adopt it. There are a lot of good ideas. There's a lot of great ideas, and a lot of them are really broad, and I was really impressed with the breadth of applicability and understanding, and some of the specific use cases, but a lot of them were pretty broad, but a lot of really great information about the potential, though, I thought, overall.
Yeah, I agree. I think I read all the papers. I think when you look through the papers, it's like, if you could probably glean the top 15 or 20 most substantial ideas that have potential for viability and some level of maturization over the next 3 to 5 years. So from that standpoint, I think it was a pretty good approach in terms of identifying areas of potential. The next step would be to figure out what's truly viable based on the OpenC and NIST partnership. It'll probably get a little bit more on the security technical side than on the patient-centric, full transparency side from my perspective.
Yeah. Yep, generally agree.
So would you expect to see a bunch more applications developed in this area, or do you think,
I think
first round is people work with what's been put out there in this group, or are there hundreds and thousands of people working on this in parallel?
I think this is really just turned up the volume on the blockchain drumbeat in healthcare substantially. I think it's given it a lot of credibility. It's certainly given it a huge amount of interest. When guys like John Halamka from Beth Israel are writing about potential solutions, it definitely gives it a kind of a seal of approval. People that were saying 6 months ago that talking about blockchain in healthcare is too far out there. It's gone past the too far out there stage to maybe there's something real here.
Right.
So
well, you guys have been talking about
think
this for a while, so nobody had to convince you two. But you feel it's going more mainstream, is what I hear you saying.
Oh, definitely. I think I don't know if it's quite at the peak of discussion yet, but it's
right.
In
the popular imagination,
it's huge compared to 6 months ago.
Right. So in the popular imagination, I think this is seen as something new and different. But my sense is that this is a technology that's been around for a while, right?
So part of the challenge is the education side. So if you think of a parent,
we lose Peter.
A couple times I tried to present mobile as a great idea, 8 years ago or 9 years ago, and it was like,
Peter?
I think we lost Peter. I'll pick up where he left off while he's breaking in and out. I heard somebody mention, people talking about Bluetooth in healthcare, in 2000, 10 years ago, whenever. And, Bluetooth is, of course, just a tool, and it kind of seems silly that people are talking about Bluetooth in healthcare back then. But I think blockchain is much broader. It's a much broader set of tools and a lot broader set of use cases, because it really is about a platform and about giving individuals more control over information. And the use cases are, part of it is that there's so many things I think that you can do with it right now. Specific to healthcare, so much of it is going to be controlled around establishing the right permissions, the right level of security for different use cases. So I think there's going to be a lot of kind of, looking at the whole tool set and then figuring out what applies where and how it's going to be controlled. So there's a lot to work through yet, but there's a lot of innovation happening already.
You kind of have two camps. You have technologists on one side, then you have this chasm, and then you have patients on the other. So it'll be interesting to kind of think about how the process happens to get these two groups to work together.
Yeah, it was a bit of an echo there, Peter. But yeah, different people coming at this from different perspectives, I think with different expectations and different desires of what we're trying to do here. So I heard from you that there's different levels of maturity, if you will, in different sectors within healthcare, or different levels of readiness. And I guess I wanted to go back to the question of sort of the permissioned versus permissionless sharing, and whether that distinction relates to different use cases. Is something, if some of the proposals were going down the path of permissioned blockchain sharing, is that for a particular use case, and does that exclude another? Or the inverse as well?
So in general, maybe we'll just start off with what permission versus permissionless is. Permissionless is really a public blockchain. So your data is not public, but a receipt of that data is public.
Right.
On a permissioned ED blockchain is fully private. So even your data is private, and your receipt is private. So it's kind of similar to back in the 90s of like an intranet, when it's like, well, we have this internet, which is everybody can access in general, and then you have an intranet, which is only accessible for that company. And we kind of have an idea of how that matured out, having worked on internets for a couple of years, having it go nowhere. I think healthcare is going to be interesting because you have a big challenge of trust in healthcare that you might not have in other sectors or other companies in general, where people are already really hesitant to provide information. And if you add that with the lack of education in general in the space, specifically as it applies to blockchain, and you mentioned, hey, it's a public blockchain. I mean, already, if I didn't have an idea, I'd be like, I don't know about public anything. And you're already kind of shutting down. So now if you're trying to get engagement through a board or through an organization, entity of leaders, it's going to be very difficult. And you're probably going to see, I agree with Leonard on this, you'll probably see pockets of like private blockchains get started where you almost have like a consortium, or, I want to say like cartel model, where you have like groups of like 3 or 8 hospital networks, and they start off with 2 or 3, physical locations, and then there's 8 and 20, and then there's a couple thousand, and they're all kind of using this, consensus-driven mechanism, but it's a little bit more like a decentralized approach versus a distributed approach. Mm-hmm. And that's probably where we're going to get the deepest traction initially. And then once people get educated, which in my opinion is like, 3 years out, then people will realize, oh, well, my data is still private no matter what I use. Oh, okay, that's cool. Why don't I try to explore an opportunity where I have a bigger network and a bigger pool of entities in terms of consensus and getting agreement? And, in healthcare, we don't really have, financial, there's not really like the financial incentives like there is on the fintech side. It's more of like, well, there's financial incentives for payers and providers, but is it really moving money that we're talking about, or is it moving information that is like a health record or medical record or diagnosis or treatment? I think in health, it's less about that monetary asset and more about that information but has different properties. And as a result, you'll need an entity to store it, but you won't necessarily need, a purely private network or consortium to do it. And it's going to take a little while on the education side before that comes around.
Great. Looks like we have Brian joining us.
Hi, guys.
Brian here. How are you, Brian?
Hey, Brian.
Pretty good. Sorry I'm late. I'm on a break from a jury trial. They made the mistake of choosing me for the first jury case in Oregon where they're prosecuting somebody for being under the influence of marijuana, a subject I know a little bit about.
Well, we won't. We'll try not to bias you on the outcome there. So while you've been talking about that, thinking about that, we've been talking about blockchain in healthcare, and just starting to talk about where we are in terms of trying to get a a foot in the door, starting to use these tools, and the opportunities that might be there. And I was about to sort of comment that there's a for the CIO class, there's a tremendous investment that's been made in other tools, other hardware, other software, and I guess I'm wondering whether people are going to see their way clear to using these tools. Is this a sort of a necessitate, a rip and replace, or is this something that can be layered in seamlessly in a way that is helpful to the current installed hardware and software?
Yeah, that's a great question. I don't know if others have already weighed in. That's one of the things that I've thought of, and in talking to, like you said, CIOs and other decision makers on, they said, oh, great. First you had direct secure messaging and FHIR, and we're finally just starting to get our minds around APIs and being able to make use of RESTful APIs to exchange, to query and respond to queries for health data. And now, what's this blockchain nonsense? And most of the time, I think they're very skeptical. Certainly skeptical about any additional costs or resources that have to be applied to trying to implement blockchain. I don't think that that blockchain is going to be, a big part of health information systems in 2017. However, I think without a doubt, it's going to be a part of our infrastructure in the next 3 to 5 years, probably more in the 3-year range.
Great. So we've had a couple of different perspectives on where the low-hanging fruit might be. Do you have a view, Brian, on what sort of what would you hit first with blockchain?
Well, having taken a look at the white papers that were submitted, both the ones that won, the winners in the ONC blockchain challenge, even some of the ones that didn't win. And there's a lot of interesting use cases. My favorite one is Ariel's from MIT Lab with John Halamka and on medication reconciliation. I think that is low-hanging fruit. They actually have proven that out, that it works, and it could be really valuable for for that use case. So, and there's others as well. If we take a crawl, walk, run approach, and we're just crawling right now, I think some of the crawl opportunities are still significant.
Yeah, and I don't think it's a near-term one necessarily, but another one that popped up quite a bit in the white papers was, and I think was part of NIST this week, was the idea of individual or patient-mediated interoperability. Mm-hmm. Going back to the idea of rather than having two institutions try and agree on a set of standards to exchange data, what if a person was able to receive this data in whatever format and tools were enabled such that the person could convert that format into another within the same kind of digital wallet or kind of off-chain blockchain kind of a structure. The idea is that what you really need is just a universal repository where you can take in data no matter what the format, and then allow for innovation to happen around how to get the data out and make it usable on an individual basis. So I think that's maybe more of a 5-year thing, but I think we'll see a lot more of that.
One thing that comes to mind is just like the idea of a bolt-on. I don't think any of these EMRs are going to be gutted and flipped, right. But we're going to see bolt-ons happen a lot sooner than 3 years, in my opinion. And what we're going to experience is some type of additional trust layer. For example, even with like an HIE or health information exchange or an all payers claim database, well, that's like a perfect use case for a digital receipt, to be able to confirm that that's the data set that was received, that's the claimant's information or the payment information, especially when we're talking about aggregating information for outcomes and not really precision analytics, but prescriptive analytics, trying to forecast the outcomes based on information. And from my experience and from my preview on those papers, I think that the HIEs is probably a pretty easy use case. And from a risk standpoint, from an executive standpoint, it's fairly low.
On the individual-based interchange of information, I was speaking with Adrian Gropper about his submission, the HIE of one. Were you thinking of that, Leonard, or other things?
It was mentioned in a few beyond just the HIE of one.
Yeah,
but,
right. Yep. So there's that trend. Peter, in terms of sort of this as being a bolt-on element, I guess my question is whether you see this as at some point in the future being part of a suite of tools that replaces the EHRs of today. I mean, it's obviously not going to happen in the next 5 years or so, but do you see a future without EHRs as we know it?
No. I mean, I was just down for the last month at a very large healthcare system down south, and it's like, no matter how much technology you add on to crappy processes, ultimately it's going to be not that efficient. So at some point, it needs to be an introspective to say, okay, what are the processes that we're leveraging to provide care, to enter clinical information like treatment and other care diagnostics before we add on additional layers of information. And even if you take out, some type of legacy system, whether it's a electronic health record and the entry, or it's scheduling, or it's billing, whatever that component is, say on the provider side, some level of information will need to be entered no matter what. So there's only so much efficiency we can kind of like squeeze out of these healthcare systems in general. And some of the inherent pains that we don't like data entry. Well, if you have a new patient, somebody ultimately has to enter some new information someplace. And if their information changes, somehow that information has to get re-entered or provided into that system, whether it's an electronic health record or a paper record. So from how this is going to really apply, I think what we'll see is, what I meant by bolt-on is, they'll start to add on receipts so that you have an understanding that that record's truly immutable. For example, maybe a doctor is looking at a patient record, and instead of either trying to validate who that patient is, they're able to look at this digital record, and maybe there's a big check mark in the right-hand corner. And if it's that data has never been changed and is the same information that the last time that health provider updated it, it has a green check. And if it's been changed, it's an X. And if there's a communication error and they couldn't validate that information is legitimate, it's a question mark. And that will be the type of experience change that will occur. But ultimately, it's going to be a very similar type of environment from an EHR or a clinical standpoint.
Okay.
Yeah, I'd say it's more like it's an underlying technology. So I don't think, it's not necessarily going to change the interfaces that people are used to working with right away. But I think it could be bolted on to the back end.
Got it. So is this an easy sell? Are people going to start using this?
I mean,
we're talking about 1 year, 3 years, 5 years. Is
Depends what you're selling to.
Yeah. Okay.
Nothing's an easy sell in healthcare. I wouldn't. It's all about where the money is, right, and the business model. So I think we've all learned that making IT processes more efficient or doing a better job isn't necessarily an easy sell in the current health IT system because of the economics. I think for pharma and for payers with specific use cases, we'll see a lot more uptake. Those who having more access to more data has a real bottom line impact, that's where we'll see the impact. That's where we'll see the uptake.
Also, when you start to look at like the broad picture of like, fee for service moving to a value-based care model, it's like, okay, well, somehow these payment, reforms and ultimately these outcomes have to be registered someplace so you can get reimbursed. Well, now it'd be nice to be able to have an auditable record that proves that the record hasn't changed for reimbursement purposes. And this type of, health financial accounting is a pretty good use case for being able to accelerate audit timeframes and other things like that. But ultimately, it kind of comes down to an innovation question. Is innovation hard to sell? Yeah, it's pretty hard to sell. The coolest innovation is like not a 15-minute pitch on what the value proposition is. People are skeptical and they need to be brought along and ultimately educated. And if you just kind of walk down a bar in Manhattan today and ask 20 people if they think blockchain is a good idea, 18 will have no idea what you're talking about. A couple will have read a Forbes article, and the last guy will be like, "What? I don't have time for this." So it's going to take a lot of education, I think, to move the pendulum over where people start to get curious enough to adopt.
Okay. Well, so it's a bit of an uphill battle, I'm hearing, but there's some good stuff around the corner, to mix some metaphors. We're coming up on the top of the hour, so I'll put it to each of you. Any last thoughts?
Do
we still have you there?
To change the world. It's just going to take some time.
Sorry, it is going to change the world? I cut you off, Peter. I'm sorry.
It's going to change the world, but it will just take some time. And, it's not a 1 to 3 year thing. It's going to be a slow emergence, but over time, it's going to change everything from, food you eat to the clothes you buy to the products that you leverage and that what your interaction ultimately is going to be.
Yeah. Yeah, so, picking up on that, I mean, what's the value of trust? Trust is not something you can point your finger at necessarily and say, oh, that has that specific value, but, over time, it has an enormous impact. I think we've seen a lot of health platforms fail over the years because there were great ideas about pulling data together, but there was very little trust in who was pulling that data together. If you put that in the power of the individuals, there's a lot of opportunity.
Yeah, so I agree with basically everything that they've said so far in the closing here. One thing, though, I would add is that there's significant movement on blockchain, particularly in financial services, fintech and that realm, whether it's Bitcoin or other cryptocurrencies, as well as other, Ethereum and other technologies based on blockchain. So yesterday I was listening to the CEO of IBM, and she was in Switzerland talking at the conference there, Sibos, and said that this is a new information technology. And she's right about that. This is going to have a big impact, sort of like the impact that the World Wide Web had, that the Internet had. And it didn't happen instantaneously, but over not that long of a period, it's changed everything. And I think that this is going to have a similar impact. I think it was Leonard or Peter said, Peter said, this is going to change everything from the clothes that we buy, how we buy them, to, where we get our food from. It's going to have a massive impact, including on healthcare. So you see big organizations with lots of resources that are committed to this technology. And so, people that think that, this is sort of a passing fad, they're surely mistaken, because there's a lot of great thought, leadership going in to solving these problems, to making blockchain applicable to pretty much every industry in the world that uses information technology. And healthcare is a a really sweet spot for this to be able to solve some big challenges that we have.
I totally agree. When we look at like just the investment, right? You start to think about like $1.4 billion, and those aren't even the stealth mode startups that are gone dark and still developing. I mean, I think we all have interactions with some of those folks that are like technically got funded, have seed money, and they can't talk about it. So NDA their ideas and really cool innovations. You know, a couple of years ago when you mentioned blockchain, kind of either people didn't understand it or they didn't know about it, or they would come down to say, well, who's really involved? And what level of dollars have been invested? And the answer was not too many dollars, not a lot of huge players. It's a lot of, you know, quiet innovation. Now, you know, Dell, Microsoft, IBM, all these different companies are starting, and Intel are starting to innovate. And CoinDesk came out and said, you know, $16 billion will be invested by the end of 2016. So up to today, from, you know, roughly 2008-ish to now, $1.3 billion has been invested, but just by the end of 2016, another $15 billion will be invested in this technology. So I think no matter what type of leader you are in the organization, at some point you have to acknowledge that these big players are innovating and they're putting their money behind their ideas. And it's possible that a couple of them are wrong, but all of the top players, you know, all of the banks, all of the top, you know, innovation companies in the world are probably not all incorrect. So people are getting to, you know, starting to get a little bit more curious.
Well, thank you all. You heard it here. Blockchain is real, and it's coming to healthcare. It's coming to a healthcare organization near you in the not too distant future. It may start small, but it will spread, and it will be here to stay. It will affect everything that we do. I want to thank our panel for joining me today. Brian Aher, Leonard Kish, Peter Nickel, all experts in this field, all with a great deal to say. And I'll be sharing some resources on the blog as we close out this National Health IT Week with the discussion of blockchain and healthcare. Thank you very much.
Thanks for putting this together, David.
Yeah, thanks David. Nice chat, Peter.
My pleasure.
Thanks,
Take
Brian.
care, all.